we treat the person, not the part of the person that hurts. Because the pill is trying to stop that part from hurting, but the person is hurting. Their whole being, we are all one being. And so to just try to compartmentalize a part and fix that, it doesn't work.
Hi, welcome to Straight Talk. I want to welcome all of our new viewers in our new cities. Welcome to Straight Talk. We talk about a lot of issues, drugs, alcohol, health issues. Hopefully you'll learn something. That's our goal here on Straight Talk. Today we're going to talk about a national issue everyone knows about, everyone's talking about it, and it's the problem of opiate addiction and heroin addiction. Painkillers. We see it in sports. We see it in our communities. It doesn't discriminate. It's everywhere. And today we're going to really focus in on how to spot it, how to help people with it, and what is the actual problem. And joining me is an expert who is a pain recovery clinician. That's Scott Dehorty. Scott, thank you for being here.
Thanks for having me.
We're going to talk a lot about this now and try to educate the public. But, you know, every day we read about it, whether it's a celebrity, you know, whether it's just someone in the neighborhood. We keep hearing about overdoses. It's in the presidential campaign.
Yes.
Never saw that before.
Right.
It's a big issue.
It's huge.
Is it as big as everyone is talking about?
No, it's bigger.
It's bigger.
It's bigger. So about 40 Americans die every day from just prescription overdose. Wow. Not even illicit drug overdose. So when we call it an epidemic, a lot of people think that might be hyperbole or just kind of a tag that we put on something, but it's bigger than everyone knows. And often the mistake people make is that they think that they go to their doctor for what most people go to their doctor for, which is pain. That's the #1 presenting symptom in medicine, the main reason people go to see their doctor. And because their doctor writes the prescription, because they then go to the pharmacy and the pharmacist hands them this bottle, that it's benign and it's safe. But it turns out that medication in that bottle is killing more people than all of the other illicit drugs combined. And it's actually killing more people than motor vehicle accidents.
Amazing.
So it has taken on this life of its own. And from my theorization, where this kind of came from is we took on the streets, right? This war on drugs, which has gone about as well as our other wars, which, you know, crack cocaine, heroin epidemic. We focused on the streets, and while we did that, the addicts went and sought their sources elsewhere, and they found it in prescription drugs. And so we saw this prevalence of pill mills, certainly in the southern states, and by the time folks kind of realized that this is what was occurring, we were 10 years behind.
Yeah.
And it had taken off.
Yeah.
And so now we've kind of gathered our sources, and now we're attacking the pills.
Do you think, you know, we talk a lot about the role of the physician in overprescribing.
Yes.
But we've gone through this whole issue of pain. I mean, I think it's probably one of our biggest problems to deal with. Nobody likes to be in pain.
Right.
Everybody wants a quick, fast, you know, solution to their pain.
Yes.
And it sounds like, you know, it's supply and demand.
It is. And here's something, as a society, we have to come to terms with discomfort is not unacceptable.
Right.
And zero pain may be unattainable for some people.
Right.
Now, I say that because I work with chronic pain patients. So I'm very empathetic, and 7, 8, 9, 10 out of pain on a daily basis is also unacceptable. And we need to do everything we can for those folks to get them better. But the traditional treatment of getting them better is actually making them much worse.
Yeah.
But I do agree that we have this society where if you feel something, you take something. And the you know, the good is often the enemy of the best. And so the quick fix leads to these long-term consequences, which end up destroying lives, killing people, and destroying families, destroying communities.
Yeah. And I think, as you say, we're beginning to wake up to realize that this is, that it's not just the heroin problem, which gets all the glamour,
right?
But it's starting with, as you say, the prescription drugs that people will get innocently.
Yes.
Or for legitimate pain.
Yes.
Do we need to do a better job at educating our physicians about addiction?
Absolutely. A much better job with education. It wasn't that long ago that in medical school, physicians were taught that if a person is in pain, they will not develop an addiction to pain medication. They really thought that the physiology would be different in the brain, as if the brain would be able to tell that, oh, this opiate is for pain, not for recreation. There's no such thing. Right. The brain doesn't know the difference.
Right.
It all goes to the same place.
So physicians get little education, probably.
Almost none. And actually,
about what real addiction is.
And the medical students at Harvard have recently kind of banded together and come out demanding more education on addiction, chronic pain, and I think we're going to see more of that because these are epidemics, these are the main health concerns, yet they're not being educated on it, so they go into their fields of medicine and they don't know the issues that they're being seen for, that they are considered the experts in.
You know, we've also opened up thousands upon thousands of these walk-in clinics where you can walk in with pain and walk out with a prescription pretty easily.
Well, and kind of a dovetail into that is when we made pain a fifth vital sign, which was done for not a bad reason. It was for late-stage cancer pain, but it's had a lot of unintended consequences.
Yeah. Now, you work with patients, chronic pain, addiction. You work at you have your own practice, and you work at Ashley Treatment Centers.
Yes.
Which is in Maryland.
Yes.
Formerly Father Martin's. For people that are watching from other cities have probably heard of that treatment center. And you're getting a lot of people with this pain. So, we want to keep this discussion going. Yeah. And talk a little more about the specific drugs and how you treat people. So thank you for being here. It's a great way to get started. And we're going to keep talking about pain medication, addiction, heroin addiction, and alternatives to hopefully help people.
Absolutely.
So thanks for being with us.
Sure.
Great, Scott. When we come back to Straight Talk, we're going to continue talking about pain medications, addiction, the biggest problem we have in this country. Everyone knows somebody that could use this information. Stay with us. We're coming right back to Straight Talk.
As a matter of fact, one of the founding members of Johns Hopkins Hospital, which is where I trained to learn about pain recovery, called opiates God's own medicine. Because if you are injured, if you are in an accident, if you get surgery, you need opiates. I mean, you have to have them. It cuts your pain off. Those are acute injuries. There is no evidence to support the fact that these medicines are helpful in any way for chronic pain conditions. And that would be any pain condition that lasts, beyond 3 to 6 months. As a matter of fact, there is very good evidence that these medications are harmful for chronic pain. And because of the dependency, you need more of the medication over time. And there's also something that's called opiate-induced hyperalgesia, which simply means you take the medication, you need more of it, and rather than decreasing the pain, these painkillers will begin to promote pain. So the longer you're on them, the more you need, and the more pain you're in.
Therefore, and then you'll need more of the medication.
You need more, and you need more, and you need more.
And there's your cycle of addiction. Now, let's take our patient again. They go in, as you say, legitimate concern, they got surgery, they get their pain medication. After 30 days, they're probably built a dependence.
Yes.
What's a responsible way that a physician should handle that patient?
Taper them off.
And what does that mean?
It means you should slowly start to decrease their doses over time. And while they've been on these opiates for a month, other modalities, other treatments should be incorporated. The medicine shouldn't be the answer. It should be a part of a treatment plan. So physical therapy, exercise, some kind of movement, some kind of regeneration of the muscles, whatever the injury requires. Oftentimes, when we're injured, it's in our nature to rest. When the injury goes beyond acute and into chronic, that rest becomes harmful, because the muscles around the injury will start to atrophy. So then when we do start to move in a normal, natural way, it's painful. And we misinterpret that pain as, oh, this is my injury. But it's actually the supporting structure around the injury that needs to be worked on.
So this physician would follow our case here, because it probably isn't being done by the physician, the tapering.
Right.
The tapering off. But what you're saying is a responsible way would be, you're going to be addicted after 30 days, and then I'll help you wean off of the drug over a month or whatever it takes to do that.
Right.
That's the responsible way a physician should probably handle it. Is that what you would recommend?
I would go beyond responsible. I would say ethical. That's part of the oath that a physician takes to do it that way. And again, the differentiator between the dependency and addiction would be the behavior that one would go to in order to obtain the medicine. So there are people that come to the pain recovery program at Ashley, and they've been on these medications for 10 years. And they've never abused their medicines. They take them exactly as prescribed, but they're on ever-increasing doses, their function continues to decrease, and their pain remains the same. They're just dependent. They're not addicted. But there are other folks who, same scenario, and they will begin to supplement the medications.
And that's what I want to talk about when we come back, because that's where this flip to heroin has gotten very popular. Scott, thank you so much. We're talking with Scott Dehorty, who is a pain expert. He works at the Ashley Treatment Centers in Maryland. He's trained at Hopkins. He's teaching us a lot. So when we come back, we're going to keep talking about pain medication and some of the alternatives that you can do to hopefully help treat them. Stay with us. We're coming right back to Straight Talk. Hi, welcome back to Straight Talk. We're having an amazing show. We're talking about pain medications, addiction, opiate addiction, heroin addiction. We see it every single day. We hear about friends of ours whose kids have overdosed, and it's a sad, sad state. And we're trying to learn about it with Scott Dehorty, who is a pain expert. He works with people that have these problems at the Ashley Treatment Centers in the state of Maryland, and just learning a lot. Scott, again, thanks for staying with us. You were talking earlier, we're talking about that the addicts, well, the person who gets a pain medicine either can't get it anymore, or it tends to be easier to get heroin, which is crazy. I mean, well, people can't comprehend this.
So the entry into opiates is pretty simple. And there was a study done 8th to 12th graders, and 67% their first use of opiates was for free and from a family member or friend, because if you do get a prescription for opiates, let's say after wisdom teeth or some sort of emergency room visit, you get a prescription for 12 or something, and you don't take them all. You put them in your medicine cabinet, you put them in your bedside table. Well, they're not seen as harmful. They're not perceived as that harmful, so someone will just take them. If that develops into something greater, or when we talk about the chronic pain patient, at some point the level of opiates become so great that either a doctor will stop prescribing, or the doctor or the pain management program will learn that they're supplementing and they cut them off. And maybe initially the person in chronic pain will start to supplement from the street. Opiates are very expensive. It's about $1 a milligram. And heroin is very cheap.
Right.
And it turns out it's much better for what you're looking for. So it's hard to think that from kind of a clean person going to heroin, that's a huge jump. Yeah. But from being in withdrawal from a large amount of OxyContin to heroin is just a little step.
Right.
And we're not talking about being in a dark alley and cooking and shooting heroin. We're talking about having a bag of heroin delivered to your house and you just have to snort it and you feel better.
Right.
So
and that's the
it's
difference,
a different world.
that it's not going in, you don't have to go into the inner cities.
No.
The inner cities are coming to the suburbs.
Absolutely.
Because that's where the customers are.
Absolutely. It's delivered.
Yeah.
It's delivered. Yeah.
Let's talk a little bit about alternatives.
Yes.
Because you work in that field.
Right.
You were talking before about physical therapy. What are other things? Somebody's in pain, you know, they don't want to take the pain pills, or they want to get off. Well, obviously, if they want to get off, they need to see someone like you.
Yes. Well, here's just to back up. Pain is not only a physical sensation. There's an emotional response. There's a cognitive response. There's a spiritual component. People in chronic pain begin to think, you know, why me? Why is this happening to me? They become isolated. So we can't just treat the physical part. Just like with addiction, addiction isn't treated by putting down the drink or the drug. You treat it from all these different components. We have to look at pain the same way. Pain is very complex, so the treatment needs to be complex as well. So when we deal with someone in chronic pain, yes, we need to treat the physical pain through physical therapy, but also through acupuncture, through massage, through yoga, through stretching. But then we have to look at the cognition of pain. And we do that through cognitive behavioral therapy. How do you think about your pain? How can we reframe those thoughts? And then we look at the emotions of pain. How do you react to your pain? Does your anxiety increase your pain? Is there trauma about your pain? Can we deal with that trauma? Do you catastrophize your pain? And then from the spiritual side, we do a lot of meditation. We do a lot of mindfulness work where it's being in the here and now rather than being stuck in the past or worried about the future. So we treat the person, not the part of the person that hurts, because the pill is trying to stop that part from hurting, but the person is hurting. Their whole being. We are all one being. And so to just try to compartmentalize a part and fix that, it doesn't work. And again, the director of the CDC, when the CDC came out for these guidelines, made a brilliant comment when he said, in no other area of medicine do we treat a non-fatal illness with a medicine that kills people so frequently. And it's happening in front of our eyes. Yeah. We have our eyes open, and it's part of the practice. So rather than doing that, because oftentimes in pain recovery, we see people way downstream, 10, 20 years after this has happened, we want to try to get upstream before this is all unraveled and try to treat the pain from these holistic aspects, meaning treating the whole person, trying to see the pain differently, trying to get a good physical therapist involved, trying to learn about meditation, learn about how to think differently about pain, not react emotionally to the pain, to kind of tense up, and treat the person in order to decrease pain. Yes, we want to do that, but we also want to improve function, because you can knock your pain out with enough medicine, right, but you can't move.
Right.
And that's not the life you want.
Right. And I think that as a nation, as you said earlier, we look for that quick, right, fast food mentality, self-medicate. We want to get rid of that pain, and we want to get rid of it now. We
right,
don't want to wait.
Right.
So these things kind of feed in to our society that wants that quick fix. Yet, as you said, it ends up being worse.
It's devastating.
Down the line.
Devastating.
So patients have to also question.
Yes.
I mean, again, it's like you say, when you're in pain, you will take that pill because
right,
you're in pain.
You want to get out of it.
But
absolutely.
Maybe both sides are responsible, doctor and patient, in discussing what's going to happen after my surgery, what am I going to do, rather than just rely on the fact that you know you're going to get a bottle of pills.
Well, and it's about planning.
Yeah.
For the person, for the chronic pain patient, for the person in recovery from addiction. If you're going in for a surgery, if this is planned, what am I going to do?
Yeah.
How long's the recovery? How much medicine am I going to get? When can I get off the medicine? Because once the opiate hits your brain, you're not thinking like you were before.
Right.
So you have to plan for that, and not just, you don't put your well-being in someone else's hands.
Yeah.
You need to be responsible for that.
This has been amazing. This has been great. I know this is a problem. I know people watching know somebody. Everybody knows somebody who's either abusing pain pills or has overdosed or knows somebody. It's a terrible epidemic. And hopefully you're able to, you know, enlighten us with some information. Hopefully people are paying attention. So thanks a lot.
Absolutely. Thank you.
Today on Straight Talk, we're talking about pain management, heroin epidemic, opiate epidemic. We've got to deal with this issue. If you know somebody that has a problem with opiates or heroin or pain, please get them help quickly. Help is available. I want to thank Scott Dehorty for being on the show. Thank you for watching Straight Talk, and we'll see you next time.